A very good morning to one and all present here. I am Dr. Avni Haryani and I would like to thank AIOS for letting me present my work on evaluation of effect of botulinum toxin on strabismus associated with DUANE retraction syndrome. I have no financial interest in the subject matter being presented. DUANE retraction syndrome is a type of congenital cranial dysnervation disorder. The main features of DRS are deviation in the primary gaze, abnormal head posture, globe retraction and overshoots on attempted adduction. The classification of DRS was given by Huber, which is based on an electrophysiological study, with type 1, in which abduction is more limited than adduction, type 2, adduction is more limited than abduction, type 3, both are similarly limited, and divided into subtypes A, B, C. Botulinum toxin is FDA approved and has been used as a muscle weakening procedure in conditions like congenital esotropia, paralytic strabismus, and thyroid orbitopathy. However, there's a paucity of literature when it comes to its role in DUANE retraction syndrome, and therefore a study aimed at assessing its effect in DRS. Our study was a prospective intervention cohort study conducted in Department of Ophthalmology, Guru Nanak Eye Center, New Delhi, for a study period of 1 year. Our study population included 25 eyes of patients with age of more than or equal to 7 years. Patients with type 1, 2, 3 DRS, both unilateral and bilateral, were taken into the study, and the patients with following complaints at presentation of ocular misalignment more than equal to 15 prism diopters, abnormal head posture, retraction and overshoot phenomenon more than or equal to grade 2. Patients with any known neuromuscular disorder, previous squint surgery or botulinum toxin injection, patent strabismus, and hypersensitivity to botulinum toxin were excluded. FDT was performed under topical anesthesia prior to injection, and Botox 50 units vial was used. 0.1 ml was injected in the concerned muscle using two prism diopter to 14.54 prism diopters at 1 week with a significant p-value, and the abnormal head posture also decreased from 11.58 degrees to 7.86 degrees with a significant p-value. The graph shows a trend of decrease in the mean angle of deviation and the abnormal head posture at different time intervals. Treatment was considered successful if the residual deviation was less than 8 prism diopters, phase turn less than 5 degrees, and globe retraction and overshoots when decreased to less than or equal to grade 1. Treatment was considered partially successful if there was any improvement but not meeting the above criteria, and failure if there was no significant improvement. On 1 week follow-up, 6 of our patients showed complete success, 12 showed partial success, while 7 failed to show any significant result. We also found out that there was a significant relation between the successful outcome and the pre-intervention FDD, with success being more with mild to moderate restriction of grade 1 or grade 2 FDD. There were also cases of mild ptosis that absolutely resolved within 2 months, not requiring any further intervention. Here we see a 17-year-old boy with bilateral type 1 DUANE retraction syndrome with esotropia, globe retraction and overshoot phenomenon. Post-botulinum toxin in the left thigh medial rectus, the esotropia, globe retraction and overshoots improved, but however limitation in adduction was noted. In the other patient, a 28-year-old girl with the left eye type 1 DRS with exotropia and a grade 2 globe retraction and a grade 4 overshoot phenomenon improved post botulinum toxin injection in the left eye lateral rectus. So the exotropia, globe retraction and overshoots, they improved. Surgery is the mainstay for treatment of DRS but is not advised anytime. There is a mismatch between surgical success and patient's expectations and desired outcomes, leading to often multiple surgeries and disappointment for both the surgeon and the patient. Botulinum toxin. In conclusion, we want to say that botulinum toxin has a diagnostic role in management of DRS. It can be used to screen patients which may benefit or worsen due to surgery, help them decide their course of action, give them an insight into their condition and help them set realistic expectations. Most of the patients who had some success post botulinum toxin injection proceeded with their decision for surgery. Botulinum toxin also has a therapeutic role as a temporary solution, but whether maintenance therapy with repeated injection is a viable option is out of scope of a study. We found out there are certain predictive factors like age, with higher success rate seen in younger age groups before the onset of muscle sequelae, and FDT has an inverse relation with the success rate. In conclusion, a prospective study which is more inclusive, has a larger sample size, a longer follow-up, and a comparative group consisting of patients who have undergone surgery post-botulinum toxin injection is required to give recommendations on use of botulinum toxin as a diagnostic and therapeutic role in DRS.